All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So you might see the background to be different and me wearing a different kind of a dress as well. So the background to this is that over the weekend, one of my colleagues, she called, she is part of our team at Dr. Bean, that she had been hospitalized for some reasons which I don't want to disclose here. And she coded thrice, meaning she was almost going to die. So now she was back home from the hospital and she needed attention. And unfortunately, her family was not around. So I have come over and I'm going to stay here till she stabilizes and is back to work. So that is the background to my background. Now, the discussion today that I want to do is the anosmia. So we talked about anosmia, or the sense of the loss of smell and taste. We have talked about it for about a year. So this was time to look back at the studies, at the pathology, and understanding if the ivermectin is still efficacious or not. And are there other drugs that can be used as well? This is a very, very important study because anosmia is quite common in the patients of acute COVID and the patient of long COVID. And sometimes if the doctor is not managing correctly, anosmia just continues to persist for months. And it is quite disturbing for the patient because all of a sudden, they cannot taste anything, they cannot smell anything, and their life just becomes so bland. So I wanted to make sure that we look at the anosmia related concepts once more. So also, Paul said that very kind of you to travel for your team member. So I actually drove 10 hours yesterday. So this place is in Oregon. So I drove from Cupertino to Oregon because we didn't have the flight right away. Plus, she was at somebody's home. So I had to pick her up on the way and bring her back to her place. So drove yesterday, brought her here. She is now much better than when I picked her up. And hopefully she would continue to stabilize and I would nurse her during this time and hopefully she'll be fine. So now let's start our discussion. This is what you get actually when you have Dr. Mobeen as a doctor. I am just that way. Okay, so let's see. First of all, I'm going to show you the studies that are part of this discussion. So this is drbeen.com. This is, once again, if you don't like Wikipedia, you can look at Olfactory Bulb from wherever you like, a book or Up to Date or other sites. Here is a free resource, so if you wanted to read it up. Then the pathophysiology, this is an important discussion here. This discussion is from 2016 June. Pathophysiology of olfactory disorders. In this discussion, what is more important is the conductive and sensory neural issues, and we will talk about that today. So please get ready today to do a deeper dive, brief but deeper dive, to understand what anosmia is, how ivermectin is useful, and what are the studies saying about it. Then there is this study about the prevalence and duration of acute loss of smell or taste in COVID patients. And then if you continue to go on, there are lots and lots of references that I have. This is a study from Mexico that I want to share as well and describe as well. And then there are a lot more things. There is one reference for which I would really love to read this paragraph as well. So this paragraph will become the summary of the problem too. So let's start. So here is the gift for humanity, which is looking for fragrance and flavor. So let's start. Let's look at this summary of this. And my apologies if you hear the traffic. This house is on a road and there is the traffic I can actually see from here. So starting with this olfactory bulb. Olfactory bulb is a if you see here in the diagram, it is a tissue, neuronal tissue, that is exposed in the upper part, or as we say, roof of our nose. On the roof of our nose, the bone there is perforated. We call it cribriform plate because it looks like perforation. So perforations are called cribriform. From those perforations or holes in the bone, the neuronal tissue is exposed out in the nose. I believe this is the only part of our body where bare nerves, naked nerves, are exposed to exterior directly. There is no other part of our body where nerves are directly exposed to the outside. This is the only place. So what happens is, the structure I would show you later on, but please know that we have olfactory nerve over here, olfactory bulb over here. Olfactory bulb has connective tissue around that as well, and we'll talk about that too. Summary is this, that what happens is that the supporting tissue. So imagine if you look at my hand here and I have a pen in my hand, imagine this pen is a nerve whose job is to smell. And then my hand is holding the pen. So this hand, if these were cells, this is supporting tissue, this is supporting this nerve. And at the same time, let's say my other hand, there is this finger here, which is the blood supply of this nerve. So there is blood supply, there are immune cells, there are connective tissue cells and other cells. We will collectively call them supporting cells. The supporting cells in the olfactory bulb area have ACE2 enzymes on them, and they have TMPRSS2 enzymes on them. And my request to everybody who's listening, please pass it on to your nurses, nurse practitioners, doctor friends, because it is so common for doctors to not know why anosmia is occurring and then not know how to treat it. So back to the discussion, the supporting cells here, they become infected by the SARS-CoV-2. When they become infected, some of them die. When they are dead, the immune cells that are present in the vicinity would start an inflammatory response. Whenever a cell dies, the cell releases damaged tissue. The inside of the cell are damaged, not tissue, the damaged cell pieces. Those are called damaged pieces, and the immune system has DAMPs, which are damage associated molecular pattern recognition receptors. So this is like trash or broken building detector. So when you pass near a place which is demolished, you can look at that and say this is a demolished place. Similarly, our macrophages and dendritic cells have receptors on them that are called DAMPs. They can detect broken cells. So broken cells themselves release cytokines, immune system will become triggered, that would release cytokine. Those release of the cytokines in turn would cause local inflammation, which would in turn cause problems with the nervous system cells that are present there, and that would cause issues with the smell. There could be anosmia, that is absolute missing of the smell, sense of smell, or there could be hyposmia, that means reduced sense of smell, or there could be paresthosmia, I've just made it up, paresthesia of the nose, which means the sense of smell has become ghost smell. So you might actually smell something, for example, let's say a meat, a piece of cooked meat, and you might, instead of smelling the meat, you might smell something else. That would be the ghost or phantom smells. So all those are possible. Now, when anosmia occurs, then agosmia occur as well, or taste issues occur as well. And what does that mean? I have said this in the past as well. Flavor is made up of the taste plus smell together. And when smell is removed, the remaining taste is something, it is still working, but we do not recognize that as a normal taste of that particular thing without the smell of that thing or fragrance of that thing. And we say we have a distaste. Okay, so continuing, this is the summary. Now, how do we fix this? High dose ivermectin. And what is the high dose that I've used? I have used, again, make sure that the side effects and person can take this. What I have done is so far 0.2 to 0.4 milligram per kilogram body weight. And within 2 to 3 days, the person recovers from anosmia. Okay, so continuing. Pathology. So this diagram, although it looks like a lot of things are here, it is actually very, very simple. Here is how to look at it. So follow me with this diagram. So starting from here, from the brain, there are smell neurons, or smelling, not smelling in a bad way, smelling, the one that are necessary for olfaction. Those neurons are coming in. These neurons are called mitral cells. They would come in at the roof of our nose inside the brain area, and they would finish there. They will make olfactory bulb in there. So this gray area, in there are blood vessels as well, and the around the blood vessels are supporting cells that are called pericytes too. Why is this all important? This is all important because we are going to say that, hey, these pericytes will get infected as well, causing a problem with the blood vessel, causing a problem with the local blood supply, and then congestion, and then issues. So that is one mechanism here that we would look at. The other is, if you see downwards, this part here is the cribriform plate. This is that bone at the roof of the nose that is perforated, and through which the olfactory receptor neurons are passing. What does that mean? So if you see here, this part, this long thread, is a neuron that is actually sitting at the roof of the nose outside of the tissues, brain tissue. Brain is enclosed in a bony wallet. We do not want anything to happen to the brain. But this neuronal tissue is sitting outside in the top of the roof of the nose. And then from there, it penetrates the bone and goes back in, and then it connects with the pericytes. So these tiny neurons, which are tasked with this sense of olfaction, they are called olfactory receptor neurons, or ORNs. Now, everything else over here is supporting tissue. And everything else over here can become infected, and then in turn cause damage to the olfactory nerve as well. Olfactory nerve and olfactory receptor neurons directly do not get infected because they do not have ACE2 on them. But when the surroundings are getting damaged, then they get damaged as well as a collateral damage. So what are these supporting tissues? For example, over here, if you see, this cell is called sustentacular cell. Then there are the microvillar cells. Then there are glands here that are called Bowman's glands. Then there are horizontal basal cells, and there are immune cells as well. All of them together with blood vessels, with pericytes, they're all making epithelium of the olfactory system, or epithelium simply means cells that are on the surface of our body. They're called epithelial cells. So this is the epithelium of the olfactory area. This epithelium is what is going to become infected. So I'm going to go to the next one a little later. This epithelium is the one that becomes infected. When that epithelium becomes infected and the local inflammation occurs, that causes damage. That causes dysfunction and damage to the olfactory receptor neurons. That can also cause further infection inside the olfactory bulb. And when the pericyte inside the olfactory bulb are infected, then the mitral cells can also become damaged, and that would cause dysfunction of the olfaction. Continuing, the types of olfactory system problems, the sense of smell issues. One is called conduction. Conduction is very simple. When we are under the weather and our nose is stuffed up, then the odorants are the pieces of the small particles in things that go in our nose and cause a specific odor. The odorants cannot get into the nose and reach all the way to the olfactory receptors because the nose is congested and the particles cannot be conducted. This is called conduction issue. It's a mechanical problem where the particles, the chemical substances that would create a specific sense of smell cannot swim all the way to the olfactory bulb because our nose is just congested. Then is sensory neural. Sensory neural mean the sensory system and the neuronal system that itself is damaged. That may be damaged inside the brain, that may be damaged inside the hippocampus, that may be damaged inside the amygdala. So inside of the brain tissues or olfactory bulb or the olfactory receptors, neuron receptors, could be anywhere, but nervous system damage will be called sensory neural. And then finally, supporting system damage, which could be ciliitis or the inflammation of the ciliary cells, or which could be, as we can see, a tentacular cell or other cells that are present here, especially parasites. Now, in case of COVID, all three mechanisms are possible. For example, if somebody develops congested nose, remember nasal congestion was not part of original COVID or wild COVID before. But slowly the newer variations of COVID, the mutations or the variants have developed further infectivity, and now people develop congestion and runny nose as well. If that is the case, then it is possible that during the acute disease, conduction anosmia might occur. If that is the case, this anosmia would go away as soon as the person recovers. Then it is possible for short time or for long time that epithelial or supporting tissue is damaged. And when that is damaged, we would not get the conduction issue problem, but we will get supporting tissue issue. And that would then cause the issue with the nervous system, leading to sensory neural issue. So all three are possible. The difference is how long will a specific anosmia occur. If it was just short-lived, then that was mostly because of the conduction or temporary supporting tissue issue. If it is long-lived, then possibly supporting tissue plus sensory neural. Now, how do we fix this? So if I go back here to this one, Ivermectin and TMPRSS2 blockers. Why? Because the supporting tissue has TMPRSS2 on it and ACE2 on it. So to block ACE2, we know that ivermectin disrupts ACE2 connection with the virus. And secondly, because we have TMPRSS2 over here, we can disrupt TMPRSS2 by proteases, for example, bromhexin. Ivermectin can actually act as a protease as well, but it is not known to disrupt TMPRSS2. So bromhexin and ivermectin can actually be very useful. In addition to that, if you wanted to give, you could give anti-inflammatory, which would reduce the inflammation in the nasal area as well, in addition to the rest of the body, and that would help as well. So now with this, I want to go over a very tiny study, but important study here. If you look at this study, this is from Mexico. Why I called it tiny, because I think number of people in here were, 35 adults, outpatient, and they had taste and smell issue. So small study. But let's look at the intervention that they did. They said that we decided to give these patients, administer vitamin D, azithromycin, and ivermectin. And look at their result. I'm just going to read this part. In this proof of concept, we show that ivermectin, azithromycin, and cholecalciferol combination in an outpatient regime is efficient in clearing viral nasopharyngeal carriage of SARS-CoV-2 in COVID-19 patients. So not just the anosmia, but viral nasopharyngeal carriage. A significant difference was observed, was observed in the combination group in the duration of symptoms and ventilatory responsiveness versus standard therapy. These results are of great importance since ambulatory treatment reduces the burden on the health system and the risk of contagion for others. So in this, they actually looked at ivermectin as well. So you can look at the rest of this part. So this is the discussion for today. What is the takeaway? The takeaway is the following. and this is what is important for the doctors. And please don't mind this appearance today, and the cameras shake. I don't have my studio system here, so I'm just using a webcam with my mic. So the takeaway is the following. Actually, I want to show you one more thing. So sorry. I wanted to read one of the latest study here. So in this study, what they did was, this is, if I go back to the date of this one, date is 25 April 2021. In this study, what they did was they did a meta-analysis of other studies that are present in various publication systems. And they came back and they said, various in vitro studies, in silico studies, in vivo studies, in animal studies, and human studies, the researchers finally come back and said, either it is a problem with the supportive tissue, or this may be a problem with the supporting tissue infection causing then nervous system tissue damage. So let's see what they're saying here. They're saying, furthermore, magnetic resonance imaging studies exhibit a relationship between a reduction on the neuronal epithelium, so the epithelium, the outside tissue, and the olfactory bulb atrophy. So not only the roof of the nose epithelium for smell, that is reduced after damage, even the olfactory bulb is also damaged and reduced in size. Atrophy means reduced in size. Damage to the non-neuronal cells, these are the supporting cells, explains the average recovery lasting a few weeks. This injury can be exacerbated by an aggressive immune response. So if you top it off with an aggressive immune response, then the injury would increase, which will lead to neuronal cell damage as well. So normally nervous tissue damage does not occur. And here we are talking about the olfactory nervous tissue, not the whole brain. So normally that does not occur, but if the immune response becomes too much, then the olfactory nerve damage would start occurring as well. And the stem cells inducing a persistent anosmia. Conductive anosmia is not sufficient to explain most cases of COVID-19 induced anosmia. Conclusion, olfactory disorders such as anosmia and hyposmia may be caused by COVID-19. The main mechanism is associated with olfactory epithelial damage, targeting predominantly non-neuronal cells. However, neuronal cells can also be affected, worsening the condition of olfactory loss. And what is the solution? Ivermectin plus bromhexin, like that category of drugs. So this is the discussion for today. I hope you liked it. Please share it with others as well, because I'm seeing a lot of patients suffering from anosmia and doctors not knowing what to do. I'm going to stop now and I'll come back online in a few minutes and we'll do a chit chat as well. Thank you very much. And in the meantime, please like, subscribe, and share. And if you would like to support this work, there are links in the description to buy me a coffee or to become a patron or to support this work through PayPal. Thank you very much, and I'm going to see you soon.